the fifth webinar in the centenary webinar series, the short papers and talking posters. I'm joined, my name is Christian Makutovich, I'm the director of the scientific program for the ASGBI, and I'm joined tonight by Mark Cheetham, who's a consultant at Shrewsbury and Telford hospitals. We've got lots of interesting talks today, and the first person who's going to be presenting is Maili Maturana, and she's going to talk to us about frailty and colorectal cancer. Over to you, Maili.
Good evening, everyone. My name is Maili. I'm an F1 at North Middlesex Hospital, here to talk about the systematic review that I conducted during my colorectal surgery job, along with the other F1s, the registrar and the consultant on the team. This is a systematic literature review looking into the effect of frailty on post-operative outcomes in patients undergoing resection of colorectal cancers. Next slide, please. As a bit of background, the majority of new colorectal cancer diagnoses are made in the 65+ age group, as shown in the graph from Cancer Research UK there. The mainstay of curative treatment is surgical resection, yet the elderly are less likely to undergo these operations. Frailty has become an important topic in many areas of surgery, and it's been suggested to be a superior predictor of poor outcomes following surgery. If we rely on chronological age alone, we risk inappropriate treatment both ways, so overtreatment of frail younger patients as well as undertreatment of more fit elderly patients. The aim of our review was to investigate the association between frailty and postoperative outcomes in patients of all ages undergoing elective or emergency surgical resection for colorectal cancer. This was done by searching for all studies reporting on postoperative outcomes for patients deemed frail undergoing colorectal cancer resections. The main outcomes that we looked at were mortality, complications, readmission to hospital, return to theatre, and length of stay. Next slide, please. A total of 17 studies were included, reporting on over 120,000 patients. These tables on the slide below show results for two of the main outcomes that were studied. So on the left, we can see a table of mortality, which was statistically significantly higher in the frail subgroup in 5 out of the 7 studies reporting on this. On the right, you can see postoperative complications, and rates of these were higher in the frail subgroup in all, so 7 out of 7 studies that reported on this outcome. Some of the other outcomes that we looked at had fewer studies reporting on them, but still readmission was higher in frail patients in 3 out of 4 studies, reoperation was higher in 2 out of 3 studies, and length of stay for frail patients was higher in 3 out of 3 studies that reported on this. Next slide, please. It should be noted that frailty assessment measures across these studies were highly variable, with 15 different assessment methods used in 17 studies. As a result, the percentage of the population that was deemed frail varied quite significantly across studies, from as low as 2.6% to as high as 60.5%. The outcome measures were also variable, with studies using in-hospital complications or 30-day complications or only certain Clavien-Dinder grades or above. But despite this, our results show that frailty status is consistently a predictor of poorer clinical outcomes in patients undergoing resectional surgery for colorectal cancer. To be able to kind of further quantify and utilize this information, there should be a more standardized frailty assessment tool. There is the opportunity to create a more specific colorectal cancer frailty index that includes areas A, proven to predict poorer postoperative outcomes, as well as B, potentially providing targets that might be amenable to optimization in the preoperative period. This would allow us to have more accurate risk stratification preoperatively, as well as individually tailored pre- and postoperative care for these patients. The exact nature of what the preoperative intervention would be is as of yet unclear, but this prehabilitation is a growing area of research, which hopefully I believe the next paper will talk about in a bit more detail. Thank you.
Thank you very much. The frailty is indeed a huge thing. What do you think is the easiest and most effective way of improving the outcomes for these frail patients? Where do you think they lose out the most?
So I think that's very difficult without having specific data on exactly which parts of frailty assessments are linked to poor postoperative outcomes. different frailty assessments are used, they tend to be quite looking at various different things. So in terms of activities of daily living, where they can be help to kind of increase their levels of physical fitness, optimizing comorbidities, making sure that vitamin deficiencies and anemia and diabetic control are optimized preoperatively. Other things that might have a relation are kind of muscle mass. So one study showed that sarcopenia and preoperative CT was actually linked to poor post-operative outcomes. So that's all stuff that could perhaps be targeted even in a relatively short preoperative period.
Very good. Let me just check if there's any other questions. No? Thank you very much, Mylis. Mark, over to you.
Thank you. So we're going to move on to the second paper this evening, and this is entitled Outcomes Following Prehabilitation for Major Intra-Abdominal Pelvic Cancer Surgery, a systematic review and meta-analysis of randomized controlled trials. And speakers Majora Nanda Kumar.
Hi everyone, my name is Majora. I'm also an F1 at North Middlesex Hospital, and as mentioned, this is a systematic review looking at prehabilitation. So following on from my colleague's concluding remarks quite nicely actually. So prehabilitation is more recently emerging as a way to improve preoperative physical fitness based on the idea that forms of structured exercise lead to improved cardiovascular, respiratory and muscular conditioning. But thus far conclusions have been quite inconsistent. So we did a systematic review of randomized controlled trials. Next slide, please. So we aim to evaluate outcomes following prehabilitation compared to a standard care arm in major surgery for abdominal pelvic cancer. And we defined prehab as any exercise or physical therapy that was prescribed and performed preoperatively. And major surgery was any that was projected to last more than 2 hours. And our primary outcomes of interest were complication rates, particularly Clevin window grade 3 and 4, as well as length of stay and readmission rates. So in total, we screened about 3,600 abstracts, assessed 60 full text articles, and eventually included 12 studies. And these studies were published between 2013 and 2019, and the total was about 930 patients. Next slide, please. So the studies involved different types of surgical specialties in several different operations, which are listed on the slide there. And in terms of population characteristics, their mean age was about 66, and ASA grade where reported was mostly 2 to 3. And we assessed the quality of randomized controlled trials using the Cochrane risk of bias tool, which showed 5 studies to be of low quality, with the remainder showing some concerns. So the results are in this table here. We calculated relative risks and mean differences with 95% confidence interval, and the primary outcomes are summarized, as well as the number of studies that reported on each outcome. And as you can see, not much there is of significance. Next slide, please. So we concluded that prehabilitation was not associated with any benefits regarding complication rate, length of stay, or readmission rate. However, there's several limitations to this study because the variable nature of the rehab program meant it was quite difficult to draw comparisons between them. So from everything from the type of physical exercise to the duration of the program and whether nutritional support was included varied between each study. And perhaps this is due to limited availability of actual evidence-based guidelines for prehabilitation. The other limitation is the quality of studies included. Overall, there weren't many randomized trials, and the ones that we included weren't particularly high quality. And not all studies included reported on each outcome of interest, so not all of them were able to be included in the meta-analysis. However, none of the participants in any of the intervention groups experienced negative outcomes that were reported. So we may see more robust evidence and higher quality studies emerge as the prehab programs themselves continue to develop. And that's it. Thank you.
Thank you very much. I think this is a really interesting area in many types of abdominal cancer, particularly colorectal cancer in my area, and I'm sure Christian has interest in upper GI cancer in this field. As you said, the problem is that the prehab programs are variable, and therefore it's difficult to compare different interventions because they're so heterogeneous. What do you think is the most likely important content of a prehab program?
I think a big one is So the cardiovascular conditioning. So some of them only really had 2 weeks of non-supervised exercise for a couple of hours a day. So I think along with a kind of more sustained period of time with cardiovascular exercise would be beneficial, as well as something that actually wasn't included in any of the studies, which was, as Mylise mentioned earlier, perhaps optimization of comorbidities. So looking at diabetic control and things like that. But unfortunately, that wasn't actually done in any of these studies.
Okay, so that leads on to a second slightly political question, which if we need to give more than 2 weeks prehab, should we abandon cancer targets, or should prehabilitation be a treatment that stops a cancer clock?
Very good question. I think perhaps we should view prehab as something that can involve a patient in their own eligibility for surgery. So rather than kind of identifying a patient who may benefit from prehab, look at patients who are in that high risk category and look at ways we can deliver prehab over a longer period of time and then assess their eligibility to cancer surgery. I don't know if that answers the question.
Yeah, okay. I think we don't know really, but I think if we can show effectiveness of a prehab program, then we probably should push in selected patients for that to stop the cancer clock, and that for the resection to be a second treatment.
Yeah.
Okay, we're going to move on unless there's any further questions.
There's nothing on the chat.
Thanks. Now, Christian, I don't know if you've seen in the chat that we've got a problem with the next.
Yeah, Dhanaraja's logged in as a attendee. Carol McNair's just messaged you. Can you re-log in as a panelist, or Carol will help you? We're going to move you to the end of the session. So the next person to present is going to be Sverrir Christensen, who's going to look at post-operative iron deficiency anemia.
Okay, good evening everyone. My name's Svaz, and this is my audit I'm presenting, post-operative iron deficiency anemia, as Christian said. And we're looking at, are we investigating and treating appropriately in our colorectal cancer resections? And by the way, I'm a CT1 in Margate Hospital. Next slide, please. So why are we doing this project? Basically, we've got a potential relatively inexpensive treatment that could be used to benefit our post-operative patients. And there is a guideline that does advise on using this. We use a lot of blood transfusions, which we know come with a lot of complications and cost. And so we wanted to find out how many of our patients were anemic and how many were we investigating and treating for. So next slide, please. So we looked at this year-long period, all elective colorectal cancer resections. We looked at the electronic records for blood results. We looked at pharmacy records, and then we conducted a brief junior doctor questionnaire to try and find out more. Next slide, please. So these are the results. So we had 83 patients, and we found that 43 of these, which is 52%, had moderate to severe anemia. And these were the ones we were interested in. These are hemoglobins of less than 100, according to the WHO definitions. And then we looked at actually how many were investigated for their anemia. And actually only 2 were investigated, which is 5%. And then we looked at how many actually received treatment for this. And it was only 14%, which is 6, received IV iron. And then obviously some had blood transfusions and things like that, but within this guideline, all of these would have potentially benefited from IV iron, regardless of blood transfusion or not. So in conclusion, the last result there, I couldn't include the whole details of the questionnaire, but basically we asked 15 of the junior F1 up to registrar level general surgery staff basic questions about IV iron, blood transfusion targets, definitions of anemia, things like this, and only 38% of the responses were correct. So in conclusion, these results show that we are firstly under investigating iron deficiency, we are under treating it, and we probably have some need for education and standardization. So what did we do? We did some teaching with the junior doctors and obviously presented the findings at the audit meeting to highlight the findings to the consultants and the more senior members. A standardized pathway was created for treating post-operative anemia, which included clear guidance on how to use IV iron and who would benefit from it. And then we also increased awareness with poster and email. And then obviously, finally, we are in the process of re-auditing to see, what benefit we've been able to lead to, but things have obviously not been going to plan recently. So we don't have any figures for that yet, but hopefully, yeah. So ready to take any questions. Thanks for listening.
Thank you very much. Nice presentation and interesting results. I'm sure it would be replicated in several hospitals, including mine possibly. You're obviously re-auditing in a difficult time, but presumably several of these patients that received blood would have just had IV iron instead to boost their iron stores and to improve their hemoglobin a bit more slowly. Have you any idea on how much money you might save by instituting your protocols?
No, that's a very good question. We, to be honest, no, we haven't really got this off the ground, but maybe that would be a good way of building
It's
momentum.
always a way of getting things into our hospital is if you find that there's good savings to be had, managers are much more interested in making things happen for you. So that's a little tip for you.
That's a very interesting point. Thank you.
Second question, obviously not many of your patients had IV iron. Did you notice any difference in the outcomes for the ones that did get IV iron?
No, we didn't study the outcomes. Well, we had not significant differences. We did, look at the 30-day mortality and things. There wasn't any difference. Okay. And actually, looking at the more bigger studies in the literature, it's very difficult to find solid evidence as to the efficacy of IV iron. There is evidence in orthopedic surgery of increasing the rate of HB increase. However, in actual real-life outcomes is difficult, but I guess that's more of an emerging field, which going from these presentations, obviously it's quite in vogue looking at this stuff.
So there's a question here from the floor, from an anonymous attendee. Have the patients not had their anemia corrected before their surgery?
Not always, and actually it's quite relying on the anaesthetist, that preoperative assessment, and some of them are quite good at referring to the anemia nurses. A lot of them are coming with quite low HBs to surgery, which was another interesting finding. The reason I didn't look more into that side is because someone else is already doing a lot of work on that side in the trust, and they're looking at it and improving it. So I was just trying to keep it simple to the post-operative side. But yeah, that's obviously a good point.
Very good. We look forward to seeing your next re-audit at the next Congress.
Yeah, look forward to it. Thank you very much.
Very good. Over to you, Mark.
Okay, thanks. So we're going to move on to the next paper, and this is entitled Stoma Reversal Rates Post Colorectal Cancer Surgery in a District General Hospital, presented by Will Woodward.
So, hi everyone, I'm Will. I'm an F1 in general surgery, currently at St Mary's Hospital on the Isle of Wight. And as you just said, I'm presenting this audit that I undertook at the end of last year and the start of this year about stoma reversal rates. The next slide, please. So what we did, we conducted a retrospective study looking at all elective colorectal cancer, all of patients who had elective stoma reformed in 2017. This is colorectal cancer patients. So we obviously looked at the operation notes, we looked at clinic letters, and we looked at imaging data to form the information for our audit. And in terms of our primary outcomes, so we wanted to know whether they had reversal discussed at clinic, preferably the first clinic after their stoma formation. We wanted to know whether the reversal was performed, if after all the clinic follow-up and the imaging, the patient was deemed suitable for reversal. And we wanted to know whether these reversals happened within the timescale that we thought was appropriate. So we decided on 6 months if they were not having adjuvant chemotherapy, or 12 months if they were having adjuvant chemotherapy. And yeah, the next slide, please. So in terms of the results, we might need to click through the slide as it goes, if that's all right. So we had 21 patients initially who had stomas formed in 2017, and click through to the next bit. So of these, 6 were not considered for reversal. So one of these patients died before they were discharged from hospital. 4 had planned permanent stomas, obviously preoperatively, and 1 was followed up elsewhere, so therefore was excluded from our study. And of the remaining 15, all 15 were discussed at clinic. The 12 of these were at the first clinic appointment, and all the rest subsequently. And then it was just looking at the suitability for these patients to be reversed. 9 of them were considered not suitable for reversal. So 3 of these were operative difficulty, 3 of these were comorbidities, and anaesthetic risk, they were deemed not suitable for that reason. 2 of these were patient choice, sort of balancing up the risks and benefits at this point. They decided to keep their stoma. And then 1 further patient passed away before they could sort of see whether they were suitable or not. And then that leaves 6 patients who were suitable for reversal. Of these, all of them had the reversal. 4 of them had it with adjuvant chemotherapy, and 2 of them without chemotherapy. So the 4 with chemotherapy, the median reversal time was 17 months, and without chemotherapy, obviously there were only 2 of them, and it was 6.5 months and at 12 months. So if we just look at the sort of conclusion from our audit on the next slide. So a couple of good points to start with. All patients had reversal discussed, and 80% of these were at the first clinic appointment. All patients who were deemed suitable for reversal had the reversal performed. However, only 1 was within the target timeframes. It's right if you just click through here. I've got some short animations. But only 1 was within the target timeframe. I think one of the patients with adjuvant chemotherapy had it a few days, under a year. And also an interesting point was that 68% of patients ended with permanent stomas, which I think is worth knowing if you're sort of counselling a patient before having these stoma formed. Obviously, a limitation of our study is that we only had 21 patients. It's quite a small study. Might be useful to audit further years to sort of increase that pool of patients. And in terms of looking at why they weren't done within target timeframes, any changes we can make, obviously at the moment, implementing any changes might be difficult, as obviously elective surgery's been suspended recently and is only just coming back at St Mary's. And obviously there's going to be quite a waiting list of things that are potentially more urgent than stoma reversals. So it might be even further down the queue at the moment. So implementing any changes that we might have found would probably be difficult. Thank you. If you've got any questions.
Yeah, can I think interesting findings, obviously small sample size, so it's difficult to make really robust conclusions. What do you think about that permanent stoma rate of 68% in people who've had temporary stomas?
So obviously that does seem quite high when you generally tell patients, I think, before they have operations for temporary stomas that there's an opportunity to have it reversed. But when if 68% of them are ending up with permanent stomas, and that seems like obviously unlikely to have it reversed if you look at those figures. Obviously, again, it's only a small sample size, so you might want to look at a larger sample. And I know there's a national audit as well that has, I think it's about 50% nationally are reversed. So slightly less end up being reversed than nationally, but again, it's a small sample size. So auditing further years might give you more information in regards to that.
And I'm interested in the reasons why. So I think the major reason why was that the patient wasn't fit, but I guess in most cases, unless they've had some kind of major medical event after the initial resection, we would know that at the time of the resection. So I suppose the follow-up question to that is, should we therefore alter the surgical technique in those patients?
So yeah, I'm not sure about that. Yeah, sorry, I'm not quite sure the answer to that question.
Well, I suppose what I'm alluding to in that group of patients who are unfit and therefore you're unlikely to want to reverse their stoma, you may as well avoid the risk of an anastomosis in the first place and do a Hartmann's procedure as a primary procedure and give them a good quality end stoma. And that's certainly something that we will discuss with frail elderly patients to reduce the risk of mortality related to an anastomotic leak. So, but I think that's something that should be discussed at the initial resection.
Yeah.
Okay, thank you. That's really interesting results. Christian, back to you.
Thanks a lot, Mark. So next presenter is is it Sophie Allen? Yes, Sophie Allen, who's going to talk to us about prehab in OG cancer. Over to you, Sophie.
Thanks so much. I'm Sophie. I'm an ST5 at East Surrey at the moment. This research was performed in Guildford over the last few years. So I'd just like to present my RCT looking at whether prehabilitation, which has recently been discussed, improves fitness in patients receiving chemo before esophagogastric cancer surgery. Next slide, please. As we know, neoadjuvant chemotherapy and surgery improves survival in patients with locally advanced esophagogastric cancer. Adequate cardiopulmonary fitness is vitally important in patients undergoing this surgery, as this operation is associated with a large metabolic stress response and significant morbidity. We know that side effects of chemotherapy include a reduction of fitness, skeletal muscle loss, and poor quality of life. The cardiopulmonary exercise testing, or CTET, is an established, non-invasive and safe method of assessing patients' fitness before surgery. Reduced anaerobic threshold and peak oxygen uptake are associated with increased morbidity and poor functional outcomes in patients having major surgery. We know that chemotherapy particularly causes an AT reduction of 2 mL per kilo per minute in OG cancer patients waiting for surgery. This was a parallel arm randomized controlled trial conducted to determine whether a prehab program improved CPET performance in patients receiving chemo before surgery for OG cancer. Patients were randomized to receive a 15-week prehabilitation program or standard care. Prehab comprised twice-weekly supervised exercise sessions, thrice-weekly home exercise plan, and also 6 sessions of medical coaching. We looked at some secondary outcomes, including skeletal mass, which was looked at on staging and restaging CT scans, grip strength, and quality of life. Next slide, please. On the top left, we see there's no difference over the course of the 3 CPETs in terms of anaerobic threshold. However, in the bottom left, we can see there was a significant difference between groups, the top line of the prehab group, in terms of peak VO2. And actually, we had some improvement in the prehab group after chemotherapy, despite this. We saw from the top right-hand graph that prehab resulted in significantly less skeletal muscle loss following chemotherapy. And despite the effects of chemotherapy, the prehab group showed improvement in their grip strength at multiple time points. So following the 3rd cycle of chemography, at their restaging laparoscopy, and on the day of surgery, whereas the control group didn't regain their strength at any point. We did a subgroup analysis of non-sarcopenic and sarcopenic patients as well, and we found that non-sarcopenic patients at baseline showed improvement in their grip strength preoperatively. And in this non-sarcopenic group, the prehabilitation subjects had a more pronounced improvement in grip strength than the controls. Next slide, please. Regarding quality of life, the prehabilitation group reported better global health status compared with the controls at 4 separate time points indicated by the asterisk. Similarly, the prehab group reported better anxiety symptoms at 3 different time points, which was preoperatively and at 6 weeks and 6 months post-op. And a lower score on this graph indicates better symptoms. The lower line is the prehab group. So in conclusion, we observed no adverse events related to our prehab program, and we had a good compliance rate with the exercise at 76%. We might therefore conclude that an exercise and psychological prehab program is safe and achievable in esophagogastric cancer patients receiving chemotherapy and can result in less skeletal muscle loss, superior peak VO2, grip strength, and quality of life. Thank you.
Thank you very much, Sophie. That's a really lovely presentation, great study, and really nice results. How do you think your results might translate into improved outcomes, and how would you show this?
We looked at some post-operative outcomes like Clavier-Dindo classification, readmission to theatre, 30-day readmission mortality. Unfortunately, because of our small sample size, we didn't see any difference between the groups. We saw a couple of trends towards the prehab group having fewer pulmonary complications, but unfortunately, because there are only 20-something patients per group, I think we need a much larger sample size to indicate that.
What are you going to do next with your project?
Well, this was my MD, which I've finished, but as a result, a prehabilitation program has been set up as standard of care for OG patients, some HPV patients, and patients having some neoadjuvant treatment before colorectal or gynae surgery. But the time frame is slightly smaller than before esophagectomy, where we've got a 15-week window. that, yeah, it's good to see it's being run.
Good, excellent. I think it's the last paper. Over to you, Mark.
Thanks. So we're going to go back to one of the previous papers, which was, sorry, I've lost my space, which is outcomes following, no, it's not, it's acute surgical unit with a purpose-built ultrasound department. Is this the way forward? And this is the presenters, Dhanaradia Arimugam. Dhanaradia, are you there? Looks like we've got some technical issues.
I can hear you.
Okay.
There you go.
Yeah. Okay. Yeah.
Do you want to carry on?
Can you see me?
Yeah, please start.
Yes. Yeah. Hello. Good evening. Thanks for giving me this opportunity. I'm presenting the impact of same-day ultrasound scan of the abdominal and pelvis in preventing unnecessary admission in acute surgical unit. So the aim is the assessment of admission rate in patients having ultrasound scan on same day and patient not having ultrasound scan performed on the same day of presenting to the acute surgical unit. And also assess the length of stay in patient having ultrasound the scan on the same day of presentation and not having ultrasound on the same day of admission. So in Rodham Hospital we have introduced acute surgical unit, and which has got a dedicated ultrasound scan list every day from morning 9 o'clock to 5 o'clock. And with the introduction of this ultrasound scan, we want to know whether we reduce the rate of admission. The Royal College commissioning guidelines recommended ultrasound scan is a fundamental to the assessment of acute abdominal pain, and in particular utility in the evaluation of particularly biliary, gynecological and renal pathology. And they also mentioned that 7-day access to the ultrasound scan is required for surgical admissions. So next slide please. So what we did was we collected data from the radiology department before the introduction of acute surgical unit and after the introduction of acute surgical unit over a period of 2 months, and the data were collected retrospectively from and in part from the computer, and the data extracted were demographic of the patient and also the day the ultrasound was ordered and the day ultrasound was performed, and the admission rate and the length of stay and the category of diagnosis. There was some exclusion when ultrasound was not the first line of investigation, and also so if you see the results and in the graph, so you can see the patients when they had ultrasound scan was only 48%, whereas when they waited for their ultrasound scan, it was about 88%. Similarly, the next graph presents for the before the acute surgical unit and also and after the establishment of acute surgical unit. Next paragraph, please. Sorry, next slide. Yeah. So this is the results. So you can see quite a lot of tables there. So there are about 3 tables. So first one is about the length of stay. So you can see and on the 4th column there is 1 day less for patients who had ultrasound scan on the same day of admission. And then the next table shows the difference of admission rate if the patient had an ultrasound scan on the same day. The percentage of patients admitted when they had ultrasound scanners only 48%, whereas when they waited for their ultrasound scan, it was about 88%.
Okay, we're having some technical issues with the sound, I think. I'm struggling to hear you.
Similarly, the next graph presents.
Can we go on to the next slide, please?
For before the acute surgical unit and also and after the establishment of acute surgical unit.
Okay, thank you for that. I'm
next paragraph, please. Sorry,
okay.
Next slide.
We're going to close there now. We lost the end bit of that presentation. Do you have 2 devices going with it? We're getting quite a lot of feedback. If you have, it would be helpful if he logs out of one of them.
So this is the results. So
okay, I'm gonna stop you there because we're not hearing this.
See quite a lot of
Dhanaraja, do you want to log out and log back in, and you've got a poster next, haven't you? So we'll put your poster towards the end, and let's see if we can sort out your technical issues.
Okay, so I think if you've got any questions for Dhanaraja when he comes back later in the program, and I think we may have to move his poster presentation further down, then we can ask him some questions on both of those. So Christian, do you want to open the next section of the?
Yeah, sure. So well done, all the short papers. This is now the talking posters. We're going to have one question after each talking poster so that you've got your one question of fame or in the limelight. First one is Alexander Yip, who's going to talk to us about telemedicine versus in-person follow-up. Over to you, Alexander.
Sorry about the audio. Good evening, everyone, and thank you for the kind introduction. My name's Alex, and today I'll be talking about telemedicine versus in-person follow-up after uncomplicated benign general surgical procedures. So what we know is that in-person clinic follow-up has long been regarded as the gold standard for post-operative surgical care. And although this is well established across a range of medical and surgical specialties, there are surprisingly very few high evidence studies that highlight its role in uncomplicated general surgical procedures, such as appendectomies, cholecystectomies, inguinal and umbilical hernia repairs. This is particularly relevant now, given the current COVID-19 pandemic, where it is expected that alternative follow-up modalities such as telemedicine will be and currently are increasingly utilized for post-operative patients. And because of this, our aim was to determine its acceptability, the patient satisfaction, time and cost savings compared with conventional in-person follow-up for these general surgical procedures. We went about this by randomizing consecutive patients that underwent a laparoscopic appendectomy, cholecystectomy or umbilical or inguinal hernia repair between February 2019 and March 2020 into two arms, a telemedicine via telephone only arm or an in-person clinic arm. At the 1 month post-hospital discharge mark, a standardized questionnaire was issued to assess our study outcomes. In terms of our results, we had a total of 130 patients, with 67 being telemedicine patients and 63 being in-person follow-up patients. Interestingly, what we found was that there was no significant difference between attendance rates, with 94% of telemedicine patients attending their appointments and 90% of patients attending their in-person appointments. And approximately 90% of patients within both groups were satisfied with their follow-up modality, which indicates to me that telemedicine actually has a very similar acceptance rate amongst patients as it does with in-person clinic. Unsurprisingly, we also found that on average, the consult duration of telemedicine appointments was over 5 minutes shorter than in-person clinic. And this consequently translates into an average saving of roughly 101 Australian dollars per consultation, which is approximately 56 British pounds. So in conclusion, we've determined that telemedicine is an accepted follow-up modality following general surgical procedures involving uncomplicated appendectomies, cholecystectomies, and hernia repairs. We also know that patients are highly satisfied with its use, and it offers them significant time and cost-saving benefits. Thank you.
Thanks a lot, Alexander. It's a really great study and incredibly topical. You must have thought it was Christmas when COVID hit and everybody's going to telemedicine. Do you think this is going to happen? This is going to go forward forever in your institution? Do you think that's what's the way that's going to go?
So what we've noticed at our institution is that for a lot of these post-operative follow-up modalities, we've now transitioned primarily to a telehealth service. Obviously, there will still always be a role for in-person clinics, particularly with those patients that may have major complications such as Clavin-Dindo 3 or above. But with that said, I do see in the future going forward that telehealth will play a large role in our health system, but a lot of that will also come down to whether or not there's government funding as well for this, and whether or not that's sustainable going into the future. From a surgical point of view, I can definitely say that it would be a great move forward and very topical at this point in time as well.
I agree. Thank you very much. Over to you, Mark.
Thank you. So we're going to move on to the next poster, which is outcomes of giant paraesophageal and intrathoracic stomach in a specialist benign DGH.
Thank you very much. Hi there, can you hear me? My name is Jack Holton. I'm one of the surgical trainees working down in South Devon in Torgay Hospital. I'm here to present our outcomes following repair of intrathoracic stomach. You can see from my poster here, we've come up with a bit of a diagram to help give some context to esophageal hernias and their progression to what can be considered an end-stage intrathoracic stomach, which can come with its own complications, which can be quite life-threatening. They can include gastric, volvulus, bleeding, perforation. Sometimes people present in real distress and need emergency surgery. Sometimes they're identified electively and they can be repaired. We identified patients over a 7-year period between November 2012 and October 2019. We had 62 cases. 16 were of an emergency repair and 46 were elective. These were identified from symptoms of reflux. Our 30-day mortality with these repairs was 1.6% and morbidity was 21%. The morbidity included early dysphagia, recurrence, urinary retention, hospital-acquired pneumonias and cardiac complications. Our conclusions from this sort of case series really were that elective repair is much more preferable to an emergency repair, but it is quite limited by a limited data series, and we could have a look more into the demographic information of the patients to understand why they had these complications subsequently. So thank you very much. Any questions at all?
Thank you. And very interesting paper. I think this is a difficult topic. These patients are often frail, and you're talking about a really big operation and complex operation in someone with limited physiological reserve. So I suppose, how would you select out those patients who shouldn't have an elective operation in that case?
I think it's very difficult. We've got, having a look through the literature, it seems to be promoted to offer an operation to those who are quite frail and elderly, despite the risks that are involved. Because it would be a very nasty way to die, frankly, if you had a gastric volvulus and nothing was able to do about it. I think you would just have to take a look at them in terms of their frailty score. There are plenty of frailty index out there that may be appropriate. But it'd be very difficult to, I suppose, deny someone an elective repair in this situation.
Yeah, I think these are misleadingly called benign operations. This is a pretty horrible condition which causes the inability to eat and aspiration pneumonia. So actually, in the majority of patients, we should optimize them and operate when possible, and as you say, electively wherever possible. Thank you. A really interesting paper with good results of a very difficult subject.
Thank you very much.
Okay. Next poster. Gosh, I can't read that small. Is it James?
Yeah, it's James.
Hi, James.
Hello.
My eyesight needs checking. You're going to talk to us about malignancy rates with simple renal cysts. Over to you.
Hello, my name's James Luco. I'm an FY2 in NHS Tayside, and my presentation is titled Overall Survival, Malignancy Rates and Intra-Observer Variability in Complex Renal Cysts. So the Bosniak classification stratifies renal cysts using radiological findings and is also used to determine malignancy risk. So Bosniak class 1 and 2 cysts would tend to be discharged straight away with no follow-up. Bosniak 2F cysts would be followed up for potential progression to a 3 or a 4 cyst, and Bosniak 3 or 4 cysts are generally resected. So the Bosniak classification can be challenging at times because of its subjective criteria, and this poses the risk of cyst misclassification. The aims of the study were to interpret the intra-observer agreement rates between radiologists when they are interpreting these cysts and categorizing them. Also to find out the progression rates of 2F cysts to 3 or 4 cysts, the malignancy rates of resected cysts, and also to compare the survival of surgically resected and conservatively managed cysts. So for the method, we used a deterministic records linkage methodology and retrospective data collection. And we looked at both overall and also renal cancer specific survival. and compared survival between the surgical and conservatively managed cysts. Statistical tests used included log rank tests, Wilcoxon tests, and also Cox proportion hazards model. So there were 439 complex cysts altogether. The kappa statistic was 0.73, which was used to interpret the intra-observer agreement rates. The progression of 2F cysts was 4.3%, and the median follow-up time was 21.2 months for those. The malignancy rates of 2F cysts that were resected was 60%, and for grade 3 cysts, it was 75.9%, and for grade 4 cysts, it was 84.5%. 73.8% of resected cysts were low stage, and 9.7% of cysts were low grade. The renal cancer specific mortality was 1.2% in surgically resected, and this was after a median follow-up period of 76 months. In the conservative group, the renal cancer specific mortality was 2.7%, and there was no significant difference between groups. If you look to figure A, is quite small. The probability of 5-year survival is much, much higher in those with less than 2 significant comorbidities compared to 2 or more significant comorbidities. In conclusion, there's a good degree of agreement between radiologists when categorizing cysts. The progression rates of 2F cysts is very low, and of those that are malignant when resected, they tended to progress within 16 months. The malignancy rates of all resected cysts were high across 2F, 3, and 4 cysts, but the malignant cysts were low grade and low stage. The renal cancer specific mortality is low amongst these patients, and deaths tend to be secondary to non-cancer specific causes. Age and comorbidities are associated with overall mortality, and patients should undergo a careful assessment before surgical intervention is recommended. Thank you very much.
Thanks, James. That's an interesting study and some nice results there. You've mentioned here that 2F cysts tend to progress within 16 months. How often do you do surveillance in those types of patients, given that they progress earlier?
So the protocol in our institution for monitoring or surveillance for 2Fs was a scan at 6 months, 12 months, 24 months, and 48 months. 24 and then 36, and then 48. So it was 6 months initially and then 1 year thereafter.
So given your results showing that they progress within 16 months, would you increase the frequency with which you're surveying them a bit earlier on?
I think increasing the frequency is actually quite difficult for the radiologist to actually be able to kind of show that there has been a change, which is worth upgrading the cyst to either a 3 or a 4 cyst. So I don't think necessarily, but what you could do is actually reduce the number of scans that are done further down the line, say 36 months and 48 months down the line.
Great, thanks a lot.
Thank you.
Over to you, Mark.
Thanks. So the next poster presentation is a re-audit of iron transfusions in the perioperative period for colorectal cancer by Katie Jones. Katie.
Hi, yes, I'm Katie Jones. I'm a CT2 at the moment in general surgery. And this poster, in kind of the spirit of prehabilitation and optimizing our patients, is a summary of the second loop of an audit that we did to look at how we were investigating and treating iron deficiency anemia in our colorectal cancer patients. So obviously it's very important optimizing our patients and reducing the amount of that they do, and choosing colorectal cancer patients in particular because they do tend towards iron deficiency anemia. So the 2 standards that we based our audit on, one was the NICE guidance for the treatment of iron deficiency anemia. The other one is the international consensus for the perioperative management of iron deficiency anemia. So you can see that in the objectives in the figure. I hope it's not too small for you. But this was a retrospective audit, so we used data from the Enhanced Recovery Programme, and we included all patients with hemoglobins below 130. And then we looked at the investigations that they had for their anemia and also what treatment they had preoperatively. So in our first cycle, we had 21% of patients that had no treatment at all for deficiency anemia. It also showed that whilst these patients were getting ferritins and CRPs measured routinely, they weren't getting something called transferrin saturation measured routinely, which obviously meant that some of the results were quite inconsistent. So then in this cycle, we did work with the Enhanced Recovery Practice nurse trying to improve this and trying to educate the senior team about the importance of investigations as well. And then we moved on to our second cycle. And we had a small improvement. 17% of our patients weren't adequately treated for iron deficiency anemia, but there is still a lot of room for improvement there. And unfortunately, we had 5 patients that didn't have adequate investigations for us to be able to classify them as iron deficient anemia. So really the problem was that we didn't have the appropriate blood results for them in order to give them the appropriate treatment. So we discussed this at the departmental meeting. We tried to understand kind of where we were going wrong. And it seemed to be that kind of we had 2 main obstacles. One was that they felt that in a time-pressured environment in the clinic, trying to get blood results back and trying to order more blood tests and sorting out iron treatment all within a target in clinic and also before they were due to have their operation was just too much. The other obstacle they had is that actually the majority of the consultants felt that this was something that should be dealt with in the community with GPs, that they should be doing the investigations and treating them appropriately before we operate. So we came from this and we tried to come up with 2 very, very clear guidelines that would be easy to follow from clinic, very simple, and that we could kind of maximize the most people that we were treating. And one of those was that basically all patients with ferritins below 30 should have an iron infusion, because the majority of patients had less than 6 weeks of their operations from clinic. So by doing that, you treat them quickly and effectively, you don't waste time on unnecessary blood tests, and you treat them appropriately according to NICE. The second guideline was that patients with ferritins of over 30 should have transferrin saturation and CRPs measured. And the idea of that is that we're avoiding unnecessary blood tests, we're trying to streamline the pathway, and also that we kind of appropriately investigate our patients, because actually, according to the international consensus, we can treat quite a broad range of our patients with iron treatment if they're appropriate. And yes, so it's an ongoing process, and then we'll try and re-audit the measures that we put in place.
Thank you. Very interesting study. So when do you think the ferritin should be measured in this patient pathway?
Well, so interestingly enough, actually pretty much all the patients had ferritins measured, because in order to be sent to a 2-week wait clinic, they had to prove they had iron deficiency anemia. So that wasn't so much the problem. I think the problem was that they would see an HB of 120 and a ferritin of 40, and they'd be like, you know, they might not benefit from iron treatment. But according to the latest guidance, they actually would. So it's about, I think, targeting those kind of investigations that we're not so comfortable with into those patients that would really benefit from it.
Thank you.
If that makes sense.
Well done.
Okay.
Christian.
Next is Ashwin Raghavendra, who's going to talk to us about a rare pathology seen in small bowel obstruction. Over to you, Ashwin.
My name is Sudhir Daniel. And my name is second on that list.
Apologies.
It was Ashwin who operated on this case in another hospital. And when he talked about this case, I thought it's a good one to present to the surgical fraternity. It's an interesting case report. And it's interesting due to 2 reasons, which I think is because we're rare pathology involved and a unique biomechanism, which I thought it involved. So it was just a 70-year-old lady who presented with small bowel obstruction, typical presentation, nothing untoward there. She had recurrent abdominal pain in the past, which relieved by itself, virgin abdomen. A CT scan showed that she had a distal small bowel cut off with chronically dilated small bowel. She went on to have a laparotomy. She had a stricture. And at the laparotomy, she was found to have a small gallstone proximal to the stricture. Unsure about the etiology of the obstruction, she had a right hemi. And the histology showed that this stricture was due to endometriosis. So this pathology with endometriosis, 70-year-old, is rare. It is usually seen in those in their 40s, 30s. Extrapelvic endometriosis is reported, but is extremely rare and commonly involves the sigmoid rectum. It can involve the ileum, but basic ileal involvement is like, in the maybe 7 to 10% or something in that range. And usually this disease starts with the serosa and involves up to the muscularis. It doesn't usually involve the mucosa. Now, in this case, the biomechanism I wanted to say, to propose was that this lady was found to have an incidental gallstone in a chronically dilated small bowel proximal to the stricture. At operation, my colleague found that the stricture wasn't too tight. It was allowing fluid to pass through. But then what caused the obstruction? Then it appeared to me that this stone might have been pushed by peristalsis, obstructing the stricture at its mouth. And when the peristalsis couldn't pass through the stricture, an anti-peristalsis results, which pushes the stone away from the stricture and resulting in fluid and gas to pass through, relieving the obstruction. This might have gone on for a while, explaining her recurrent abdominal pain. And then one fine morning, she presented with a small bowel obstruction. So this actually gave me some resemblance about the soda bottle, cognac bottle, which as such in my younger ages I've seen, but not anymore. And hence I thought, well, it's nice to present it. Well, this is the case. I've seen a few case reports of and literature review of endometriosis in the small bowel, but nothing suggesting a dual mechanism, something that involves the mural stricture with an intramural cause as a cause of small bowel obstruction. So hence I thought, well, let's present it. Thank you.
Thank you very much, Sudhin. That's really interesting. Did the resected specimen have just the one gallstone in it, or were there several?
No, just the one.
Just the one.
Yeah.
And I'm not suppose the CT scan, we've just got the one shot of the stricture there. Was there any aerobilia to show that there was a cholecystoduodenal fistula?
No, there was no aerobilia. So that obviously rose to, the question rises then, what is it? Just a kind of a fecolith that because formed due to the stagnation, or there was enough time passed so that the aerobilia got absorbed by itself? I don't know.
Very interesting.
Yeah.
Thank you very much.
No problem. Thank you.
Now, I think the next one is Dhanaraja. If we've got his, let me just check.
Yeah.
Have we got his IT issues sorted?
Can you hear me?
Yes,
can
we
hear.
can.
Yeah, can hear you.
Okay, so I'm going to present about the need for extended DVT prophylaxis after major abdominal surgery. Is it mandatory? Whether it is worth giving somebody after surgery 28 days of tensiparin injection after their major cancer surgery. So the introduction is, as you're all aware, there is high risk of thrombosis in patients with cancer, and venous thromboembolism is one of the common type of the thrombosis associated with cancer. So patient NICE guidelines recommends anybody who had major surgery for cancer of the abdomen should have 28 days of thromboprophylaxis from the day of surgery. But in our trust currently, we are giving only tensiparin injection during this stay in the hospital, not for 28 days. So we wanted to see whether we need to change our practice. So what we did was we collected the data of patients who underwent surgery from the period of April 2015 to November 2019 in our trust, and there were about 442 cases. And we checked each patient eyes in the system whether any of them had ultrasound scan or CTPA since the time of discharge. So we found out out of 442 patients over the period of 4 years, 40 patients had investigation after discharge in the form of ultrasound scan and also CTPA. Out of this 40 investigations, 12 were positive. That is about 2.7% had venothromboembolism post-discharge. And out of this, if you look at the time frame, 2 patients were diagnosed with DVT within less than 28 days, and another 2 cases were diagnosed from the time 1 month to 3 months period, and then 4 cases were diagnosed from the period of 3 months to 6 months period, and 4 cases were diagnosed after 6 months of their discharge. And we looked at the Cochrane review as well, and they had done a study and they found out instead of 28 days, they did a 14-day Tinsipar injection, and they scanned everyone whether the patient had Tinsipar injection or they didn't have Tinsipar injection, and they found out there is a big reduction in incidence of DVT when patient had a Tinsipar injection for 14 days. So their result shows that from they studied over 839 patients. Out of that, only 1 patient had DVT when they received the Tinsiparin, whereas 8 patients developed if they didn't have the Tinsipar injection. So from this, the conclusion is that so we need to, in order to improve the patient safety, we have to extend the day of Tinsipar injection to 28 days post surgery.
Okay, thank you. That's an interesting study.
Yeah.
I'm just looking at your methodology. This group incorporated the 40 patients who had been investigated post-operatively. Is that right?
Yeah, that's right. Yeah.
It's just that your conclusion said only 1 patient had extended VTE prophylaxis. I'm sure that some of the more than one of the 440 did. I'm sure.
Currently, they don't give it in our trust. Only one patient had, because the patient was diagnosed at the time of admission. So rest of the patients, when they're discharged, they go home without any DVT prophylaxis currently. So since we've done this, we presented the local audit, and then we made a provision that patients who have major surgery, particularly when their mobility is not back to normal, and then it is included as a part of discharge summary. So we have to mention whether this patient needs extended DVT prophylaxis, yes or no, and then it automatically, if you say tick X, yes, and then it automatically opens another box where you have to prescribe the Tinsipar injection for 28 days as recommended by the NICE. So that's what our conclusion is now.
I mean, this has been NICE guidance for some years now.
Yes. Yeah.
I think this is a big thing. I've recently been reported to the GMC for a patient who died of a fatal PE post-discharge. Actually, the patient had major trauma, and we elected not to give him extended prophylaxis, and he then had a thoracotomy elsewhere. But I ended up with a slightly sweaty 6 months while the GMC investigated me. So there's a real political thing behind all this VTE prophylaxis. So it is important. And avoidable harm in the NHS is a real thing at the moment. Thank you. Interesting paper.
Thank you very much, Mark. I completely agree with you there about extending your VTE prophylaxis. We certainly do. I want to thank all the panelists, all the presenters. Thanks to Vicky and Carol for your IT support as always. We wouldn't be able to do it without you. Please have a look at the e-posters on the website. There's some really good topics and interesting studies there for everybody to look at. And join us again next week. Thank you very much. Bye-bye.
Thank you.
Okay, thank you.